In today's session, we will be discussing managing patients on opioid analgesics. My name is Noah Cooperstein. I'm a board-certified family medicine physician. I'm a full-time faculty member at St. Louis University Southwest Illinois Family Medicine Residency Program. I practice a mix of inpatient and outpatient medicine, treating patients with acute and chronic pain, often in the setting of overlapping conditions of opioid use disorder, substance use disorder, and HIV. I have nothing to disclose. We have 4 primary learning objectives for today's session. Apply strategies for responsibly initiating treatment with opioids for patients in acute pain. Review the application of opioids in the setting of chronic pain. Learn to safely monitor patients on opioid analgesics. And review ways to mitigate opioid misuse and harm. Today's session is based largely on the 2022 CDC Clinical Practice Guideline for Prescribing Opioids for Pain. This guideline is, of course, cognizant of the ongoing opioid epidemic. At the same time, it presents a balanced and, frankly, thoughtful approach to the application of opioids for patients who need them. It's not overly prescriptive or rigid, and it acknowledges that opioids, when used responsibly, can be part of a comprehensive plan of care for managing both acute and chronic pain. Throughout the course of this session, we'll be referring to the risks associated with opioid analgesics. These are some of the most prominent warnings and most salient considerations when prescribing opioid analgesics. There is, of course, the risk of life-threatening respiratory depression in the setting of an overdose, and this risk is greatly exacerbated if there is concomitant use of benzodiazepines or other CNS depressants, including alcohol. There are well-known gastrointestinal effects, namely constipation, and there is the risk of addiction and misuse. There's also the consideration of drug-drug interactions, as there is some cytochrome changes induced with opioids as well. And just in the most basic sense, there is impairment associated with these medications, and that can be a consideration for patients who drive for a living or operate heavy or dangerous equipment. All right, let's jump right in with a case. But rather than me giving you a case, I'd like you to take just a second to think of a patient you've seen recently in acute pain. Maybe the patient presented with low back pain or neck pain. Maybe they have pain related to some other musculoskeletal injury, like a sprain or a strain, a tendinitis or a bursitis. Maybe they had a recent minor surgery, like a dental extraction, or maybe they just have dental pain. Other considerations could be a kidney stone or a headache. For our purposes here, let's assume that the patient you're thinking of has been adequately evaluated, that they don't need additional workup or intervention at this time, and that there is otherwise a good plan of care, is to say x-rays or physical therapy, already outlined. And our task here is to just address their pain. Where do we begin? While this session is about managing pain with opioid medications, we cannot ignore the role of non-opioid medications and non-pharmacologic options for pain. The safe and effective use of opioid analgesics is built on a foundation of non-opioid management. And in many cases, non-opioid therapies are at least as effective as opioids for many common types of acute pain. And it's important to maximize the use of these non-pharmacologic and non-opioid pharmacologic therapies before or during the administration of opioid options. And the safe and effective use of non-opioid medications is discussed elsewhere in this series. Some of the common acutely painful conditions where non-opioids will likely be as effective or even more effective than opioid therapies include low back pain, neck pain, pain related to other musculoskeletal injuries such as sprains, strains, tendinitis, and bursitis, pain related to minor surgeries, a dental extraction being the quintessential example here, dental pain in general, kidney stone pain, and headaches, including episodic migraine. Just a quick note to avoid dichotomous thinking around opioid pain medications for these common painful conditions. There sometimes seems to be a perception among both patients and clinicians that opioids really would work better for these conditions, but that for whatever reason, the clinician is holding back. Maybe they're concerned about safety or addiction or diversion or abuse. But it's important for clinicians to internalize that opioids typically will not work better. And in fact, when we offer, for example, an NSAID for back pain or ankle sprain, we are in fact offering the most effective treatment available for that. We're not holding anything back, and we're really offering the best possible plan of care. There are instances where opioid pain medications are indicated immediately. Opioid therapy has an important role for acute pain related to severe traumatic injuries, including crush injuries, burns, long bone fractures. It plays an important role in invasive surgeries and other severe acute pain where NSAID and other therapies are contraindicated or likely to be ineffective. In these cases, longer durations of opioid therapy are likely to be needed when there's a severe mechanism of injury that's just known to result in prolonged severe pain. Patients who do require longer-term opioids for acute pain should be evaluated every 2 weeks if they continue to receive these medications. While described in detail elsewhere in this series, I at least wanted to mention the most important non-opioid analgesics to consider for acute pain. They are acetaminophen, non-steroidal anti-inflammatory medications, and skeletal muscle relaxants. Returning to our case, we were considering a patient in acute pain. Maybe the patient has a strain or a sprain, maybe they have acute back pain or a kidney stone. Whatever the case, what are the key considerations when thinking about starting an opioid pain medication? Well, for one, we should think about how long the patient's been in pain. And if they're in moderate to severe pain, we should consider if their pain has not been responsive to the non-opioid medications that we were just discussing. Furthermore, really, we should only consider opioid therapy for acute pain if benefits are anticipated to outweigh the risks. And before prescribing opioid therapy for acute pain, clinicians should discuss with patients the realistic benefits and known risks of opioid therapy. Just as a reminder, in many cases, opioids will not be better than non-opioid alternatives. And clinicians should really ensure that patients are aware of expected benefits of, common risks of, serious risks of, and alternatives to opioids before starting or continuing opioid therapy. And patients should be involved in this decision about whether or not to start opioids. And many times a patient arrives with acute pain, and it's tempting to assume that they want an opioid, but this is not always the case. Many times patients just want something for their pain, and they don't know what. We should help engage them in that decision so that we can find really the best treatment for them. When prescribing opioids for acute pain, make sure that non-opioid medications are optimized first. This usually means around-the-clock prescription for these medicines. Additionally, opioid medication should be written PRN rather than scheduled or around the clock. Make sure to give an appropriate quantity based on expected duration. Give the least amount, the lowest dose for the shortest time required. When prescribing, typically think about a 3-day and really generally try to avoid more than a 7-day prescription. And before writing any opioids, if at all possible, you should consult the Prescription Drug Monitoring Program website. The 2022 CDC guidelines emphasize a couple of key points repeatedly. When diagnosis and severity of acute pain warrant the use of opioids, clinicians should prescribe immediate release opioids and avoid long-acting or extended-release formulations. They should prescribe at the lowest effective dose and for a duration no longer than the expected time of pain severe enough to require opioids. In many cases of acute pain, when opioids are needed, a course of just a few days is often sufficient. These shorter courses minimize the need to taper and prevent withdrawal symptoms at the end of the course. However, the duration of prescription really should be individualized to the patient and their clinical circumstances. Clinicians should, in almost all cases, avoid prescribing additional opioids just in case the pain continues longer. Really, for this strategy to work, you'll need to reevaluate the patient frequently. Another note here, for postoperative pain related to major surgery, there are procedure-specific opioid prescribing recommendations available with ranges for amounts of opioids needed. This is based on actual usage data and refills and the consensus in the surgical community. If this applies to you, I would encourage you to seek out those specific resources. For opioid-naive patients in acute pain, prescribe the lowest effective dose. The lowest starting dose for opioid-naive patients is often equivalent to a single dose of approximately 5 to 10 morphine milligram equivalents, or a daily dosage of 20 to 30 morphine milligram equivalents. A listing of common opioid medications and their doses in morphine milligram equivalents is provided here. And morphine milligram equivalents moving forward will sometimes be referred to or shortened to MME. Opioid conversions are still a rather imprecise science. There's no exact way to say that one opioid is equal to exactly this much of another. And because of that, there's a lot of variation in conversions, especially with some of the online calculators. This table was adapted for the 2022 CDC guidelines, but other tables are available, and another recommendation is the table from Practical Pain Management, which is available online. A couple of things to note here. Hydrocodone is generally considered to be a 1-to-1 conversion into morphine milligram equivalents. So 1 milligram of hydrocodone can generally be considered equal to 1 milligram of oral morphine, while oxycodone is generally considered to be more potent, with 1 milligram of oxycodone equal to 1.5 morphine milligram equivalents. As I mentioned at the start, the 2022 CDC guideline really is balanced and thoughtful. They point out that the recommendations related to opioid dosages are not intended to be used as inflexible, rigid standards of care, but rather as guideposts to help inform clinician-patient decision-making. This really is a guideline in the truest sense, and it still allows clinicians to use discretion so that they can treat the patient in front of them in that moment. Bear in mind, though, that risks of opioid use, including risk of overdose and overdose death, increase continually with dosage, and there is no single dosage threshold below which risks are eliminated. However, the guideline, rather than emphasizing a single specific numeric threshold, recommends that clinicians avoid increasing dosage above levels likely to yield diminishing returns and benefits relative to risks to the patients. And that balance between risks and benefits is going to be determined by innumerable factors unique to the patient that you're seeing in that moment. When prescribing opioids, make sure to write your prescriptions for only as-needed use. For example, hydrocodone, 5 milligrams, acetaminophen, 325 milligram, 1 tablet not more frequently than every 4 hours as needed for moderate to severe pain, rather than prescribing them on a scheduled basis. That would be 1 tablet every 4 hours, for example. In general, avoid around-the-clock opioids and scheduled opioids. But should you encounter a patient who's been on around-the-clock or scheduled opioids, consider a taper if this has been an ongoing dosing schedule for more than a couple of days. It's worth pointing out here that the role of extended release and long-acting opioids is really very limited in the setting of pain. Do not treat acute pain with extended release or long-acting opioid formulations, and do not initiate opioid treatment for subacute or chronic pain with extended release or long-acting opioid formulations. And additionally, really these long-acting or extended release formulations should never be written for intermittent use. So if you're following the guideline of writing as-needed opioids, you're never going to write an extended release formulation. Extended release formulations, of course, do have a role in chronically painful conditions in treating patients who have already been exposed to and been on immediate release opioids for some duration of time. Before starting any opioid pain medications, clinicians should ensure that patients are aware of the expected benefits, the common risks, serious risks, the alternatives, and really patients should be involved in the decision about whether or not to start opioid pain medications in the first place. Oftentimes, patients will present with some kind of pain, and there's a temptation to assume that the patient is asking about opioids. This really is not always the case. In fact, many patients do not want opioids, even in situations where an opioid would not only be appropriate, but probably indicated. So this discussion of risks and benefits cuts both directions. Some patients need to be aware of the risk of overdose because they might take too many, but in other instances, a patient might be afraid to take a single hydrocodone because they're afraid of addiction or overdose. And really, in that instance, the risk is quite low. Occasionally, a patient will be started on opioids for acute pain, and then the duration will drag on for 3-4 weeks. At this point, you have to be careful that the patient isn't transitioning into more of a subacute or chronic pain picture. Look for reversible causes of chronic pain, and make sure that your opioid prescribing for acute pain does not unintentionally become long-term opioid therapy simply because medications were continued without reassessment. Now, that's not to say that opioid pain medications don't play a role in subacute or chronic pain, but the decision to initiate long-term opioid therapy needs to be an intentional one, and it needs to be part of a comprehensive pain management plan. It's not something that should happen by accident simply because prescriptions are being refilled continuously. Just a reminder that when prescribing initial opioid therapy, and then periodically through the course of opioid therapy if it's ongoing, to check the patient's history of controlled substance prescriptions using the state prescription drug monitoring program. Now, in this case, you're not just looking for other opioid prescriptions, but you're looking for other controlled substances that might be dangerous in combination with opioids, specifically benzodiazepines. Ideally, at every visit, the patient's medication list will be reconciled in the EHR, and there'll be a quick check of the prescription drug monitoring program. Now, in a busy practice, it may not be practical to check the PDMP on every single visit, but at a minimum, for patients on longer-term opioid prescriptions, it should be checked every 3 months. And again, it certainly should be checked at the first prescription of opioids. Now, the PDMP is really in existence for patient safety. It should never be thought of as something that's punitive. And so its application should really be unbiased and the same for all patients. Whatever you find on the prescription drug monitoring program information, though, a patient should never be dismissed from your practice on the basis of this information. This has a couple adverse effects for the patient. It can harm their safety and honestly results in a missed opportunity to provide some good care to the patient. Whenever we're talking about pain, and especially if we're talking about issues of substance use disorder, we always have to start by meeting the patient where they are, not necessarily where we would want them to be. The PDMP allows us to continue to verify the patient's actions moving forward, though, so we're not relying entirely on blind trust. Additionally, safe prescribing practices discussed in this session will help insulate the patient from further harm. Be forthright with your patients. Discuss information from the PDMP with them and confirm that they are aware of any additional prescriptions they might be receiving. Because clinicians often work in teams, you may see prescriptions written by multiple providers, and in some instances, this might be okay. If you do have safety concerns, discuss them with the patient, including the risk of respiratory depression and overdose. This is especially true for patients who are found to be receiving multiple or overlapping prescriptions, especially if these prescriptions are from clinicians who are not directly coordinating the patient's care. The same applies when finding combinations of medications such as opioids and benzodiazepines that represent a safety risk to the patient. If you do find these combinations, or you do find that a patient has more opioids prescribed to them than they should, consider offering naloxone at that visit. If you are concerned that a patient is diverting their medication, that is to say, sharing it or selling it and not actually taking it themselves, consider getting toxicology testing to help determine whether prescription opioids can be discontinued without causing withdrawal. If the patient has a negative toxicology test for the prescribed opioid, it might indicate that they're not taking it and that the medication could be stopped or not prescribed further. At the same time, be cognizant of the fact that there is a possibility for a false negative or misinterpretation of these test results. So be certain you understand the test and how to interpret its results before making any patient care decisions based on it. Now, let's take a second to consider a different case. Again, I'd like you to think about a patient you've seen recently, this time a patient with chronic pain. Now, maybe they have back pain or osteoarthritis, maybe it's headache or fibromyalgia, pelvic pain, or abdominal pain, but some chronically painful condition. I would point out here, though, that for our purposes, we're not going to be discussing chronically painful conditions where opioids are the standard of care, the two most prominent examples being sickle cell disease and cancer. So when seeing a patient like this, what is your first step? Well, especially if the patient is new to you, but even if you've been seeing them for a while, it's a good idea to confirm your diagnosis and make sure there's not some other pain driver or some other diagnosis that's been missed. And again, before starting opioid therapy for any kind of pain, especially chronic pain, make sure the patient has a realistic idea of the benefits they can expect from opioid therapy. Work together with the patient to establish treatment goals for pain and function. What would they like to be able to do that they can't do now? And consider how opioid therapy will help them reach those goals, if it will at all. Additionally, you'll need an exit strategy. Make sure to have a plan for how to discontinue opioids if the benefits are just not there, or if the balance of risks and benefits changes. Make sure you're optimizing and recommending appropriate non-invasive, non-pharmacologic approaches. Generally speaking, opioids should not be considered first-line or routine therapy for any chronic condition. However, this does not mean that patients should be required to sequentially fail non-pharmacologic and non-opioid pharmacologic therapy or be required to use any specific treatment before proceeding to opioid therapy. Rather, the expected benefits specific to the clinical context should be weighed against the risks before initiating therapy. And again, patients and clinicians should internalize that opioid pain medications are not going to be the answer here, that even if prescribed, the patient's pain is not going to instantaneously resolve, and any treatment needs to happen in the context of a larger plan of care. At the same time, in some clinical contexts, for example, where there's a serious illness in a patient with a poor prognosis who's unlikely to return to their previous level of function, or in situations where there are contraindications to other therapies, or in a situation where a clinician and a patient agree that the overriding goal is patient comfort, opioids might be appropriate regardless of previous therapy. Compare this to other situations, a couple of which we've mentioned already, headache and fibromyalgia, for example, where the expected benefits of initiating opioids are almost certainly unlikely to outweigh the risks, regardless of previous non-pharmacologic and non-opioid therapies used. When initiating opioids for chronic pain, make sure that your first prescription is for a short duration, preferably 1 week. You're also going to want to reevaluate that patient at 30 days or sooner. Use the lowest effective dose of opioid pain medication, recalling that any increased dose increases risk. Avoid long-acting or controlled-release opioids in general, and specifically avoid these in opioid-naive people. Avoid methadone or transdermal fentanyl as any kind of first line. And when seeing the patient back for reevaluation, assess improvement in pain and function in addition to any adverse events they may have experienced. Before starting and periodically during continuation of opioid therapy, make sure to evaluate your patient's risk for opioid-related harms and discuss these risks with the patient. Work with your patients to incorporate into their management plan strategies to mitigate risk, and this may well include offering naloxone. Now, naloxone has come up a couple of times, so let's discuss this life-saving medication in a little bit more detail. There are a few ways to decide whether or not to prescribe naloxone to a patient. One option is to assign the patient a score using the Risk Index for Serious Opioid-Induced Respiratory Depression. This score takes into account things like liver disease, lung disease, kidney disease, and sleep apnea. It also scores points for the use of long-acting opioids and concomitant use of benzodiazepines. Additionally, it takes into account previous adverse events. And typically, a score of over 32 would be considered an indication for naloxone provision. The CDC recommends a simple morphine milligram equivalent threshold of 50, where any patient over 50 milligram of MME per day would be a good candidate for naloxone provision. And finally, good old-fashioned history taking. The greatest predictor of overdose is previous overdose, and certainly if a patient has had a previous overdose on opioids, you should consider providing naloxone. But independent of any score or threshold, any patient on opioids who you feel would benefit from a naloxone prescription should be provided one. The 2022 CDC guideline takes a similar history-based approach. So any patient with a history of overdose, any patient with a history of substance use disorder, any patient with a history of sleep disorder breathing, namely obstructive sleep apnea, any patient on greater than 50 MME a day, and any patient taking benzodiazepines should be provided with a prescription for naloxone. One additional key point here is that for a subset of patients who are at risk for returning to a high-dose opioid, for which they may have lost tolerance, you should provide them with naloxone as well. If a patient has had a previous opioid overdose, use extreme caution in considering whether to prescribe them any additional opioids at all. The risks may well outweigh the benefits in these cases. And, just as a heuristic, anybody who has ever overdosed on opioids should have naloxone, not only prescribed, but they should be counseled to keep it with them basically at all times. There are several formulations of naloxone available, both parenteral and nasal. There are also parenteral autoinjectors. However, the nasal spray seems to have become one of the most popular, and it does mitigate some of the risks with bloodborne pathogens related to an injection. There are some key things that patients must understand about naloxone. First and foremost, that it will save your life. but that it can also kill you. Naloxone has a shorter half-life than many opioids, so patients who overdose can overdose a second time in the hours following a naloxone administration. Patients must call 911 or go to the emergency room if they receive naloxone, even if they feel fine after its administration. If a patient is to go back to bed or go about their business, there's a very real risk that the respiratory depression that needed to be reversed in the first place will return. And now in the setting of the naloxone that was available having been used up. This is an extremely dangerous situation that patients need to be aware of. As of March 30th, 2023, the FDA approved an over-the-counter naloxone nasal spray. This is breaking news, and the implications for prescribers and patients alike are evolving. For patients taking opioid pain medications for chronic pain, it's rare that increasing the dose will improve the patient's pain or alter their functional status. And in general, clinicians should avoid increasing the dose of opioids for chronic pain. Similarly, it's unlikely that morphine milligram equivalents of greater than 50 per day are going to offer any benefit to the patient's pain or functional status. They will, however, greatly and progressively increase the risks associated with opioid use. Again, this 50 MME threshold is not hard and fast, but be very conscientious and deliberate in assessing patients who are either requesting additional pain medicines or who you feel may need to go over that 50 MME threshold. And if there is a need to increase the dose, do so by the smallest practical amount. Whenever maintaining patients on opioid pain medications for any amount of time, the risk of dependence and abuse comes to mind. There are ways to at least try to identify patients who might be at risk of abuse. There's the opioid risk tool and the screener and opioid assessment for patients with pain. There's also the brief risk interview. However, review of the clinical evidence for these tools demonstrates limited and variable accuracy for classification of patients at low or high risk for opioid use disorder or misuse. The old mantra of, when all else fails, talk to the patient, continues to hold true here. In one study, a single screening question, for example, the question, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons, with an answer of one or more considered to be positive, was found in a primary care setting to be 100% sensitive and 73% specific for the detection of drug use disorder compared with standard diagnostic interview. Other validated screening tools, such as the Drug Abuse Screening Test, DAST, the Tobacco Alcohol Prescription Medication and Other Substance Use Tool, TAPS, and the 3-question version of the Alcohol Use Disorders Identification Test, Audit-C, can also help identify patients at risk for misuse or abuse. This table provides information about some of the most common screening tools for misuse. Regardless of which screening tool you use, if any, always remember that such risk scores should not take the place of clinical judgment. Risk prediction models can be considered one tool among many, and remember, as clinicians, we use the tool and not the other way around. When prescribing opioids for chronic pain, certainly before starting opioids and periodically during their administration, clinicians should consider the benefits, but also the risks of toxicology testing. Toxicology allows clinicians to assess for prescribed opioids and other prescription and non-prescription controlled substances that may be in the patient's system and increase the risk of an overdose when combined with opioids. Toxicology testing should never be used in a punitive manner. It's solely another tool to gather clinical information to inform and improve patient care. Clinicians should never dismiss a patient from care on the basis of toxicology testing alone. Similarly to our discussion with the PDMP, dismissal from the practice could have adverse consequences for patient safety, potentially including the patient obtaining opioids or other drugs from alternative sources, and clinicians missing an opportunity to facilitate treatment, both for the patient's pain, but also potentially for a substance use disorder. The application of toxicology testing in your practice should be standardized across patients, and this recommendation of using toxicology testing should be applied globally. Discuss the expected results with the patient, that is to say, that you expect to find the medicine that you've been prescribing and that you would not expect to find other medicines or illicit substances. But do this in a non-judgmental manner and provide space for the patient to discuss the possibility of unexpected results. It is up to the clinician and the patient to decide the implication of a test positive for cannabis. Bear in mind that in many states, the recreational use of cannabis is now allowed, and there is even some evidence that the use of cannabis will increase the need or demand for opioid medications. Generally, toxicology screening can be achieved using a relatively inexpensive presumptive immunoassay panel that will test for opiates as a class, benzodiazepines as a class, and several non-prescribed substances. But bear in mind that this screening is just that, and it's not going to detect all drugs in a class. For example, some of the synthetic opioids, such as fentanyl, will not be included in the widely used toxicology assays that screen for opioids as a class. For example, a test positive for opiates on an immunoassay would detect morphine, which might reflect a patient's use of morphine or codeine or heroin, but it does not detect synthetic opioids and might not detect semi-synthetic opioids. Moreover, in some cases, a positive result for a specific opioid might reflect a metabolite from another opioid that the patient is taking and is supposed to be taking. There are a few reasons to consider getting confirmatory toxicology testing. For one, if the toxicology results will inform decisions with major clinical or non-clinical implications for the patient. For example, if they were or weren't in violation of a pain management contract. Or number two, in an instance where a need exists to detect specific opioids or other drugs within a class, such as those that are being prescribed or those that cannot be identified on standard immunoassays. And number three, and perhaps this is the most likely, if there's a need to confirm unexpected screening results on a toxicology test. For example, the patient is tested positive for an illicit substance but adamantly and repeatedly denies using such a substance. Now, when describing toxicology testing, it's often happening in the context of a patient treatment agreement. These are sometimes referred to as pain contracts. It's important to note that there's actually no data to support the efficacy of treatment agreements in reducing misuse or abuse. One of the most important aspects of a treatment agreement is usually in the first line and typically states something to the effect that the patient will work together with the provider to develop the safest and most effective treatment plan possible. So while there's a tendency to focus on the toxicology testing aspect of these treatment agreements, it's actually this collaborative aspect that is so key to making these work. Whenever starting opioid therapy or titrating up opioid therapy, make sure to follow up with patients within 1 to 4 weeks to evaluate both the benefits and the risks that the patient is experiencing, and continue to regularly reevaluate these benefits and risks throughout your time caring for the patient. When seeing a patient for monitoring of chronic pain treated with opioids, periodically evaluate for changes in the underlying condition. Rather than increasing opioid doses, consider switching to a different medication in the same class and then actually decreasing your dosage by 25 to 50% to accommodate for cross-tolerance. Make sure to monitor for adherence to the treatment plan, and as discussed, this may include toxicology testing. And finally, evaluate for signs of opioid use disorder. There are a couple specific medications that warrant extra consideration and caution, namely benzodiazepines and long-acting opioids. If a patient requires treatment for anxiety in the setting of chronic pain requiring opioid pain medications, consider an evidence-based psychotherapy such as cognitive behavioral therapy or specific antidepressants or non-benzodiazepine medications approved specifically for anxiety. If a patient is receiving benzodiazepines from another clinician, it's worth considering getting in touch with that clinician and simply discussing the patient's needs, prioritizing their goals, and talking about the risks and benefits of concurrent benzodiazepine therapy in the setting of opioid exposure. Occasionally, extended release or long-acting opioids will be indicated for a patient, or a clinician will encounter a patient who comes to them already on these medications. These medications, by their very nature, have an increased risk of overdose, and the clinician should plan on following up with patients starting long-acting formulations at a maximum of 2 weeks of treatment. There will be some instances where a patient is already receiving long-term opioid therapy and require additional opioids for superimposed severe acute pain. This could be a major surgery or a new or different trauma. In these cases, additional opioids should only be continued for the duration of pain severe enough to require an increased dosage. The patient should be returned to their baseline opioid dose as soon as possible. This may require a taper back to the baseline if the additional opioids were used around the clock for more than a few days. Okay, let's finish up on a few notes about patient counseling. We've already discussed the importance of managing patient expectations. Patients should anticipate improvement of their pain with a mixture of non-pharmacologic, non-opioid, and potentially opioid modalities. The Food and Drug Administration, as part of its Opioid Analgesic Risk Evaluation and Mitigation Strategy, REMS, has released the Patient Counseling Guide, What You Need to Know About Opioid Pain Medications. Use this guide as part of your discussion with patients and caregivers when prescribing opioid analgesics. Okay, we made it. Here are a few take-home points. Make sure to optimize non-pharmacologic and non-opioid treatment modalities, whether or not you are prescribing opioid pain medications. When prescribing opioids, use the lowest effective dose for the shortest duration with PRN or intermittent dosing, and make sure to use immediate release formulations. Follow up with patients frequently. If it's a new opioid prescription, a maximum 1-month follow-up, and for chronic opioids, a maximum 3-month follow-up. Make sure to manage patient expectations about the effectiveness and efficacy of opioids compared to non-opioid options, and continue to investigate with the patient whether the opioids are meeting their treatment goals, including sustained improvements in pain and function, and determine whether the patient has experienced any common or serious adverse events or early warning signs of serious adverse events, or has signs of opioid use disorder. Use toxicology screening and treatment agreements deliberately as mechanisms to improve patient care, and never use these things punitively or as a reason to dismiss a patient from your practice or apply them in a biased manner. Check the PDMP frequently, ideally at every visit, and discuss the role of naloxone and prescribe this medication liberally. Closely monitor patients taking higher risk regimens, and that would include patients on greater than 50 MME a day, or patients who are using opioids in combination with benzodiazepines. Additionally, this includes patients on long-acting opioid formulations. And finally, provide patients with the REMS Patient Counseling Guide so that they have something to take home for reference to help them understand their opioid prescription.